Hello, everyone, and thank you for being here with us. I'm sure none of us will ever forget the moment we heard the words, your child has cancer. In that instant, the life as we knew it changed forever. We're thrown into a world where we never imagined, where everything from the words we use to the way we live each day is different. On top of that fear and heartbreak, we suddenly had to make critical decisions about the treatment, clinical trials, and care, and often without having enough guidance. When my little boy was diagnosed with neuroblastoma, I desperately searched for information, anything that could help me understand what we are facing and how to make the best choices for him. We traveled all over the world hoping to get him the best treatment available. But nothing about this journey is easy. It affects not just your child, not just our child, but the entire family, and every decision is overwhelming. That's why we started this webinar series, to make sure parents had access to the knowledge they need directly from the experts who dedicate their lives to treating and researching neuroblastoma. Every month, we bring in specialists to share insights, answer questions, and help us navigate this incredibly difficult reality. This is our third session since launching the series on December 5th at the Neuroblastoma Awareness Day. Our goal remains the same, to support families by giving them the tools and information they need to face this disease. With that, I'm honored to introduce Susan Cohn. Dr. Susan Cohn has spent her career caring for children with neuroblastoma and advancing research to develop better treatments. She has mentored pediatric oncologists worldwide and currently serves as Director of Faculty Development at the University of Chicago's Comprehensive Cancer Center, and she is also the co-chair of the INRG Task Force. Among her many accomplishments, she was awarded the 2022 Lifetime Achievement Award from the Advances in Neuroblastoma Research Association. Today, Dr. Cohn is with us today to talk about diagnosis and staging, which are critical in determining our children's treatment plan and tracking their progress. These factors play a key role in deciding the best course of action for each child. So we are incredibly fortunate to have her today to share her expertise with us. Dr. Cohn, thank you for being here. We're so grateful to learn from you today.
Thank you so much. It's an absolute privilege, and I'm delighted to be here and to talk to all of you. I'm going to pull up my slides. Okay. And as was stated, I'm going to give sort of an overview about diagnostic tests, how we stage patients with neuroblastoma, and then risk classification, which is how we stratify therapy. These are my disclosures. So I'm sure as many of you know, I'll just give them an introductory neuroblastoma slide. This is the most common extracranial solid tumor in children. And the tumor originates in neural crest tissue, which sits in the sympathetic ganglia, which are these nodules here, this neuronal tissue that goes up and down near the spine, as well as in the adrenal medulla, which sits on top of the kidney. What's really fascinating about this tumor is its broad spectrum of presenting signs and symptoms, and it also has a very broad spectrum of clinical behavior and response to therapy, which reflects its biologic heterogeneity. Survival differs very much according to the age the patient is at the time of diagnosis, their stage, histology of the tumor, as well as some tumor-specific genomic markers. And modern therapy is tailored according to the predicted risk of relapse, which is based on clinical and biologic markers. Now, anytime a child is diagnosed with neuroblastoma, of course, the question always arises, why did my child get neuroblastoma? What caused this? And what I can tell you what we know, which is that there doesn't appear to be an environmental factor that contributes to the diagnosis of neuroblastoma. but it does appear that there are certainly genetic predisposition factors that can cause neuroblastoma. Very rarely, in only 1 to 2% of patients, is there a family history. So sometimes there's multiple cases of neuroblastoma within a single family, which obviously suggests that there's a gene that's contributing to the development of neuroblastoma in these cases. There have been a subset of cases that have been associated with something called congenital central hypoventilation syndrome and/or Hirschsprung's disease. And in these cases, a mutation, a germline mutation, so in the germline DNA, your normal cell DNA, a FOX2B alteration has been detected in some of these patients who then also develop neuroblastoma. But these alterations are very, very rare. This is not the most common reason for families to see neuroblastoma in their family. What has also been identified more recently in a landmark paper, actually by Dr. Mose, and I'm going to show you some of the data in the next slide, is germline mutations in the ALK gene has been detected. And most of the familial cases that have been identified, ALK mutations are detected. However, there are other families in which neither FOX2B nor ALK gene mutations have been identified. And so there's clearly other germline mutations that can also lead to familial predisposition to neuroblastoma. So this is the pedigree that was published in the paper that Yael Mose published in 2008. And just to orient you, each one of these schemas here represent a family. The filled in boxes are males with neuroblastoma. The filled in circles are females with neuroblastoma. And the way these pedigrees are displayed, if the patient or subject is alive, there is no line through the symbol, whereas if there is a line through the symbol, the patients have died. So just again, looking at this relatively simple pedigree, you can see that here there's a grandparent who had this mutation that subsequently was inherited. And in this particular generation, even though the mutation was inherited, this female did not get neuroblastoma. But this female then had 2 children with this person and 1 child with this person. Both these males were wild type, and you can see all 3 of the children developed neuroblastoma, but they all survived. And then you can see here, there's other pedigrees in which patients with neuroblastoma have died. So this demonstrates very clearly that in these particular families, there is a genetic etiology to the predisposition of neuroblastoma. Now, what is ALK? ALK is actually a receptor. It's called a receptor tyrosine kinase that's involved in the development of central and peripheral nervous systems. So it's in normal cells, it's required for central and peripheral nervous system development. What had been found approximately 20 years ago or so is that in adult cancers, there were translocations or fusions with this ALK gene and another gene. So the chromosomes would fuse together and develop, you'd have these fusion forms that led to an activation of ALK and an activation of the ALK pathway that was driving the cancer. And this has now been reported in anaplastic large cell lymphoma, non-inflammatory myofibroblastic tumors, as well as a number of other cancer types. In neuroblastoma, as I mentioned and showed you in the pedigree, ALK mutations were detected in the germline. So I'm not talking about tumor tissue, but the germline of DNA in patients with a family history. There were also studies that have demonstrated, however, that ALK mutations, as well as amplifications or multiple copies of the ALK gene, have been identified in a subset of tumor tissue in patients without a family history. So we can see ALK mutations in the germline or the normal DNA in the normal cells. And then there's also some patients, a subset of patients that will have mutations or amplification in the tumor tissue. Now, how does neuroblastoma present? This is really a disease that can present with many, many, many different symptoms. And so sometimes when you take your child to the pediatrician with some of these symptoms, it may not be entirely clear that what you're dealing with is a neuroblastoma. And sometimes it takes a little while to determine what is causing all the symptoms that the patient has. Occasionally, patients will present with asymptomatic masses, or you can feel like a fullness in the neck or in the chest or in the belly or the pelvis without any other pain whatsoever. There's something called Horner syndrome, which involves the stellate ganglia, which is one of the very top ganglia along the vertebral body that I showed you. And when this ganglia is involved, it affects the eye and it causes drooping of the eye. It can cause a restriction of the pupil. And sometimes it can interfere with sweating on that side of the face or body. Sometimes if the tumor grows from the sympathetic ganglia into the intraspinal space, it can actually compress the spinal cord, and that can cause all sorts of problems with spinal cord compression or nerve compression, and that can result in either back pain or sometimes neurologic deficit like weakness in the legs. Sometimes the tumor will spread to the bones around the eye, and that will cause sort of black and blue eyes in the orbit area, and that's called raccoon eyes. Sometimes the tumor spreads to the liver, and that can cause a big liver. And then there's also very nonspecific systemic symptoms like weight loss, irritability, fever, high blood pressure, diarrhea, and then something called opsoclonus myoclonus, which is a neurologic condition of abnormal eye movements and abnormal balance. Occasionally, patients can have bone pain due to tumor that's spread to the bone. Sometimes patients can look very pale because there's tumor that's spread to the marrow that's interfered with blood production. And patients can also present with skin lesions. So you can imagine that there's many, many, many things that, for example, can cause bone pain or can cause weight loss or irritability. And so sometimes it does take a little while to figure out exactly what's going on here. To make a diagnosis of neuroblastoma, you either have to biopsy the tumor and then you see unequivocal pathologic evidence of neuroblastoma, which are these small round blue cell tumors that are very typical of neuroblastoma. And sometimes you can make the diagnosis if you see tumor cells. These clusters of cells are tumor cells in the bone marrow, but you have to combine that with elevated urine catecholamines, elevated HbA and VMA. So that's the other, these are international criteria for diagnosing neuroblastoma that were published in '93. Now, what about evaluating stage? How do you determine what the patient's stage is or their extent of disease? This is done with tumor imaging. It can either be CT and or MRI scan, and this is just a picture of an MRI scan here, so you can see that this is evidence here of a tumor that's a paraspinal lesion that may well, I can't tell from this picture, but it's possible that it may have been actually infiltrating into the intraspinal space. And so that patient will need to be evaluated for that and determine whether or not this is a medical oncology emergency. Then in addition to CT scans, you can also see soft tissue metastatic lesions on the CT scan as well as the primary tumor. We also do MIBG scans, which is a radio-labeled nuclear medicine scan, and these are just pictures of those. This is an MIBG PET CT, and this is that same patient just with a 2D image. And again, you can see that this area that we assume is tumor on the CT scan indeed lights up with MIBG scan on both of these images. And this is a very nice way to evaluate extent of disease and particularly metastatic disease. And here you can see that the legs and the arms, as well as the skull, have uptake, indicating that there's more likely than not evidence of marrow disease in this region and or bone disease. Some tumors are not MIBG positive, and in that particular case, typically we use FDG PET to evaluate the extent of disease. And then you also need to evaluate bone marrow disease, and that's typically done with bilateral bone marrow aspirates and biopsies. Now, prognostic factors are not new. Audrey Evans and Dan DeAngio, who are pioneers in the field of pediatric oncology, actually published the prognosis of stage and age in 1971. So we've known that there are clinical features that will very much determine how a patient will do. And even in the 70s, if you're less than 1 year of age, your survival rate was 82%. And if you had localized stage 1 disease, your survival rate was 80%. So you can see that there were certain patients who did very well, namely infants less than 12 months of age, as well as patients with localized disease. Whereas those patients who had stage 4 disease had a significantly worse outcome. Here's more recent data. This is data from the CCG Pediatric Oncology Group and the Children's Oncology Group from more than 20 years ago. And we used a little bit of a different staging system. Evans stage was a imaging staging system. This is a surgical staging system in the International Neuroblastoma staging system. And here you can see if you had either localized disease or stage 4S disease, which is a very special metastatic pattern in infants that's associated with a high rate of spontaneous regression, your survival rate is substantially different than if you have stage 4 disease. So this is just looking at outcome according to stage. As I mentioned, age is also highly, highly prognostic and associated with outcome. And Audrey Evans used 12 months as her cutoff for a good versus a bad age for a patient. Wendy London and colleagues subsequently took all the CCG data that she was able to analyze, more than 3,666 patients that were diagnosed between 86 and 2001, and took a look at how each increment of age affected outcome. And as you can see in this particular survival curve, there did appear to be a little bit of a cutoff here between ages 13.5 months and 16 months. And there was statistical evidence to suggest that we could use a different cutoff beyond 12 months of age. What was adopted was 18 months. And this would allow some patients who otherwise would be considered higher risk because their age was over 12 months and they'd receive very intensive therapy, they could be treated with less intensive therapy and not suffer the consequences of the high-risk treatment. Now, there have been these prognostic factors available for a long, long time. Like I mentioned, stage and age have been around since the 70s. Since the 80s, we've known that the status, or whether or not this oncogene and MYC was amplified or not, was prognostic of outcome. Something called tumor cell ploidy, which is a way of measuring how much DNA is in the cells, has been prognostic of outcome for decades, as has tumor histology. Additional chromosomal markers of individual specific chromosomes, such as markers on chromosomes 1, 17, and 11, were shown to be prognostic in the late 80s and 90s. And then over the last 25 years, as technology has changed, we've really identified numerous other ways to evaluate genomic markers that have prognostic significance. But these haven't quite made it into our current classification systems. And right now, as I'll show you, we're really still using largely very old prognostic factors. So this is the Children's Oncology Group Neuroblastoma Risk System that was developed in 2006. And again, here you can see we're using INS as stage. The age of the patient, 547 days, correlates with 18 months. So we've incorporated 18 months. We take a look at whether the tumor's NMYC amplified or not. We take a look at the tumor cell ploidy, whether the histology is favorable or unfavorable. And then they're assigned to various risk groups, either low, intermediate, or high. And then treatment is stratified based on this risk group. So if you take a look at what's been done, again, using data that's over 20 years old, even 20 years ago, if you were classified as low or intermediate risk, your outcome was really quite good. And this was substantially different than those patients who were classified as high risk, where clearly we were not doing a particularly good job in terms of curing this cohort of patients. So what we've done over the next 20 years is the primary aim of our COG studies has been to reduce therapy in this group that does very, very well, and see if we could maintain this excellent outcome with much less intensive toxic treatment. These are largely little children. Many low-risk patients are infants. And if you can avoid treating them with increased doses of radiation and chemotherapy, that would obviously improve their long-term outcome and decrease their risks from treatment-related toxicities. Now, clearly, the focus for the high-risk patient was to improve their outcome by increasing treatment intensity and identifying new effective therapeutics. And I know that you're going to be getting a number of different talks during this series. And I believe Dr. Bagatelle spoke to you recently, and so I'm sure she went through some of the new treatments that are ongoing in the Children's Oncology Group to try to achieve these goals. Now, if you take a look at Europe and SciPen, which also has conducted numerous important randomized clinical trials for patients with neuroblastoma, they defined risk a little bit differently than COG. So their definition of low risk is kids that were less than 18 months of age who had unresectable localized tumors. You can see there's no stage. They did not use INS stage in this particular classifier. They had intermediate risk patients that were less than 12 months of age with disseminated disease involving these particular areas. High-risk patients were greater than 12 months with stage 4. So you can see there were definite differences between SciPen risk criteria and COG risk criteria, which very much limited our ability to compare our high-risk studies to the European high-risk studies. And that ends up being a big problem because neuroblastoma is rare and we want to speak the same language so that we can determine if there's something that's being done in Europe or in Japan or in China that works best for a specific subset of patients than what we're using in COG, that we're able to determine that. So in 2005, Andy Pearson, who is from the UK, and I were asked to co-lead a task force to develop a common language for us to speak around the world. So we developed what we wanted to call the International Neuroblastoma Risk Group Classification System. And we all met in Canada in 2005. We invited 52 investigators from all over the world, and we had multiple different types of investigators came to this meeting, including clinical trialists, biologists, genomicists, radiation therapists, surgeons, statisticians, and we all sat down and tried to figure out what classifiers we should integrate into a uniform risk group schema. And the way we did this, because everybody had their favorite prognostic marker, is we wanted to do this with a statistically robust analysis. And we were able, from all over the world, to collect data on over 8,800 children with neuroblastoma who were diagnosed between 1990 and 2002. And they were enrolled in various clinical trials across the country, across the world. And we took a look at 36 different potential prognostic factors, and we analyzed statistical and clinical significance of these factors using something called a survival tree regression analysis. And this was all done, was led by Dr. Wendy London, who is the statistician that really guided us in terms of how to identify factors that were important for specific subsets of patients. And the factors that were prognostic of event-free survival were identified and then integrated into the classifier, the INRG risk classifier. Now, the surgeons in the group very much said that because this is a pre-treatment risk classification system and surgery is part of treatment, we needed to develop a new staging system that was not surgical. And they really felt strongly that your stage should not be based on where you go for surgery, because you could have a very, very large infiltrative tumor and it might be surgically resected at one institution and biopsied at another, and that would lead to a different stage. So they were very strong proponents of developing a new staging system, which we called the International Risk Group Staging System. And the stage was based on image-defined risk factors. And these are just examples of some of these image-defined risk factors. So for example, the tumor encased blood vessels, which would make surgery much more difficult, or the tumor compressed the trachea, or the tumor infiltrated into blood vessels in the liver, or the tumor infiltrated more than a third of the spinal canal. And if you had evidence of these image-defined risk factors, that made surgery more difficult. And in fact, this was what was adopted. I mentioned in SIOP, they used unresectable tumors as one of their risk classifiers. And so this was very much similar to what they had been doing in Europe for a very, very long time in terms of looking at tumors and whether or not they could be resected. So this is just the paper where we reported this new staging system, and a localized tumor without image-defined risk factors is L1, a local regional tumor with an image-defined risk factors in L2. Stage M is distant metastatic disease, and MS is very similar to stage 4S in this very special group of patients. And this INRG staging system has now been adopted around the world. So this is the INRG pretreatment classification system that we published in 2009. Again, INRG stage, we used 18 months as our cutoff here. We did use some histology features like histologic category, grade of differentiation, NMIC was included. We were able to take a look at a couple of chromosomal aberrations, and we found that 11q, loss of 11q, was indeed prognostic in certain subsets of patients, and ploidy was also included. And you can see what we did was classify patients as very low, low, intermediate, or high. And again, the hope was by defining these patients similarly, then cooperative groups could develop treatments for these various categories of patients, and we would be comparing the same types of patients at all over the world. And this, we thought, would end up really advancing our opportunity to identify treatments that were going to lead to improved outcome. Now, very shortly after this was published, SIOP adopted this because they were essentially using the INRG staging system prior to the development of this classifier. But COG had a number of ongoing clinical trials in which INSS was used. And so there was a delay in adopting this particular classifier. But as I'll show you a little bit later, in 2021, a new COG classifier was developed and has now been adopted, which is very, very similar to this INRG classification system. Now, the other thing that we did in the INRGs, again, we wanted to make sure that we were measuring things the same. And so we created white papers, consensus reports of how do you evaluate and make amplification, for instance. What's the detection of minimal disease in bone marrow? How do you interpret MIVG scans? How do you interpret image-defined risk factors? We wanted to make sure that everybody was clear on what constituted an L2 versus an L1 patient. And then we also had a workshop to develop unifiers. So if somebody has a partial response to treatment, we wanted to make sure that that definition was also uniform. Now, the data analyzed to establish this classifier, which I said was published in 2009, so quite a long time ago already. The original cohort was treated more than 20 years ago, diagnosed 1990 to 2002. The available prognostic factors, as I said, were limited in terms of what we had available in that era. And there have been new diagnostic markers that have been identified that were not included in the original analysis. And so we recognize, that this risk classifier, as I assume the next version of the classifier, will continue to be refined as we learn more about biomarkers and have the opportunity to reanalyze data with patients who were treated in different eras. And one of the very powerful biologic biomarkers that have been identified is the chromosome copy number and aberrations. And this was all work that was done by Gudrun Schleiermacher and the Siapin group, and they were able to demonstrate there are different types of aberrations that can be identified. These are called array CGH, where you can look at whole genome array copy numbers. Instead of individual, like I said in the past, we just looked at individual loss of chromosome 1 or chromosome 11. Now we could look across all the chromosomes, and you could determine if there was, here's evidence of a gain of chromosome, the entire chromosome 2 is gained. This is an example of partial gain of chromosome 2. Here you can see NMYC is amplified, which is located on chromosome 2. Here's an example of 11q loss. And so they were able to take a look at different combinations of either numerical or segmental aberrations, plus or minus NMYC, and they classified these different types of genomic patterns. And then what they were able to show is that these patterns very much correlated to prognosis. And you can see if you have a type A pattern, which is numerical gain of chromosomes, your outcome is substantially better than if you have some of the other patterns. So here's the new COG risk classifier that I mentioned that was just recently published a couple years ago. And what we've done is we've integrated INRG staging system, and these are just flow diagrams to show you that you take into account the patient's age, you take into account their tumor, was it completely resected or not, take into account whether or not the tumor is NMYC amplified, and then patients are classified as low. This is provisional low because this is an observation where there is no actual surgery done, or high risk. And the same can be seen for L2, where you take into account, again, age, histology, the status of tumor cell ploidy, NMYC, and segmental chromosome aberrations. And for this particular analysis, we took a look at 7 loci. And here's for the metastatic disease, stage M and MS. And again, we've included now the segmental chromosome aberrations in this analysis. So it's taken into account, hopefully, to improve risk classification. And we can hopefully refine treatment according to risk more refinedly. Now, there's been a whole explosion of new biomarkers that have been identified by new technology, including next-gen sequencing. I know many of you are completely aware of ALK gene mutations, as I mentioned in the very beginning of the talk. In tumor tissues, mutations have been identified in approximately 4% of diagnostic tumors. Amplification of ALK has also been identified, and this is a recent paper that was published using the Siapin recent high-risk study, where they took a look at outcome according to whether or not patients had or did not have evidence of ALK aberrations. So here are patients who did not have any aberrations. They may have had amplification, something called a clonal aberration, which is the mutated allele fraction is greater than 20%, or subclonal, which is mutated alleles were identified, but in a very small percentage of the allele fraction. And as you can see, these different aberrations were indeed associated with overall survival. The clonal aberrations in this particular analysis had a worse outcome than patients who had subclonal analysis. And if you just took a look at whether there was an alteration or no alteration, again, you can see that ALK did indeed impact outcome. Now, ALK is also a predictive marker, and we know that if you have an ALK mutation, then you're much more likely to respond to a drug that will inhibit the ALK pathway. So ALK can be used both as a prognostic marker and a predictive marker to help determine treatment. The other thing that next-gen sequencing has identified is aberrant telomerase maintenance mechanisms. And this is a pathway that's involved in maintaining telomeres, which are there's repeat sequences at the very end of chromosomes. And as we age, these chromosomes get smaller and smaller. But if you maintain them, that will improve survival. And so retrospective analyses have shown that activated mechanisms to maintain these telomeres are prognostic of outcome. And now ongoing prospective studies are being conducted to determine whether or not this can be confirmed in a prospective study. And if indeed it does confirm and validate the retrospective analysis, the next step will be to determine how we can integrate this particular genomic marker as a prognostic biomarker in future classifiers. The other thing that's been identified is there are new technologies and ways to measure gene expression at the RNA level, and there have been a number of expression signatures looking at multiple genes that have also been shown to be highly prognostic of outcome. And here's an example of one paper. It's this particular paper by DePreter and colleagues, in which you take a look at a high-risk patients on their particular protocol. And you can see that this prognostic factor, if you took a look at the tumor tissue expression pattern by the signature, there's a substantial difference depending upon whether you had what was considered to be a favorable signature versus an unfavorable signature. Do want to mention that in addition to evaluating markers at diagnosis, there's also a very powerful prognostic marker that we have now identified that can be identified after diagnosis, and it's a clinical factor, and it's actually response. And so a couple of years ago, Naveen Pinto and colleagues did an analysis taking a look at multiple high-risk studies that were conducted in the COG and CCG and POG. And what he showed was that those patients at the end of induction, so after receiving 5 to 6 cycles of induction chemotherapy, those patients who achieved a partial response or better did substantially better than those patients who didn't respond, both in terms of event-free survival and overall survival. And so this, of course, has led to the question is, can we do something to improve the end of induction response with more effective treatment? And if indeed we improve end of induction response, will that lead to better outcome? And I believe, as I said, that Dr. Bagatelle probably presented some of the ongoing studies. This is a study that's recently closed, in which we did add MIBG therapy in induction, and we'll see when the study is finally analyzed whether the introduction of this particular radio-labeled treatment will lead to improved end of induction response and then ultimate outcome. The other question that's being asked is there other ways, are there better ways than just scans to take a look at response? And circulating tumor DNA in blood samples has been developed. Multiple technologies have been used to detect circulating tumor DNA in the blood using a variety of sequencing the DNA in the blood samples, as well as taking a look at DNA marks or epigenomic marks on tumor DNA, and that can distinguish tumor DNA from other DNA in the blood. And these tests have been used to detect prognostic markers such as disease burden. So you can use them to say how much how much tumor DNA is circulating, and that corresponds with the burden of disease in the patients. And you can also take a look at this liquid biopsy or blood test to take a look at mixed status, segmental chromosome aberrations, and also ALK variants. So you don't necessarily need a biopsy of the tumor to determine some of this. Right now, the biopsy of the tumor is what is standard, but this is becoming utilized much more readily and may well replace tumor tissue as we move forward. The beauty of liquid biopsies is that, of course, you can draw blood at multiple times during treatment. And so it's a very useful technique to monitor response. And you can even determine early relapse. I'm just going to show you a little bit of a study that we did at the University of Chicago that was published a couple years ago now, where we were looking at the marks on the DNA. And this particular mark we were looking at is something called 5-hydroxymethyl-C. And we did a retrospective analysis, very small number of patients that were seen at the University of Chicago. We took a look at well children as well as patients, and then we had a validation cohort. And then we did these hierarchical clusterings of profiles. And we were able to demonstrate both in the discovery and the validation cohort that there were 4 clusters of patients that corresponded to the diagnosis, relapse, during therapy or at the end of therapy. And so those patients in blue were patients who had very little disease, whereas the patients here on the left were patients that were at diagnosis, relapse, or just when they were beginning their therapy. And we had a couple of patients in which we were able to do serial profiles, and we were able to demonstrate that the serial profiles correlated really nicely with clinical response. And so we concluded that, again, if we can validate this in a prospective study, this may be another assay that we could use to evaluate response. And it may identify those patients who are not responding to particular therapy, and you could make decisions to change that therapy sooner with a blood test instead of waiting, until the end of therapy or the end of induction, for example, for all the scans and the bone marrows. So what we're doing is in the study 1531, which is the one I showed you, where we're randomizing MIBG, we've integrated blood sample collection throughout the therapy. And these samples are being sent to both Boston and the University of Chicago. In Boston, the sequencing analysis is being done, and at the University of Chicago, we're analyzing our DNA marks to see if we can use this to help inform response and treatment. We do not have, obviously, we don't know who's alive, who's dead, who's relapsed, who's not, because the data haven't been released yet. But this is something called a PCA plot, and it just shows you, for example, at baseline, all of the dots. We've done this now in over 1,000 samples, kind of correlate right here, and then they have different marks. They correlate differently. They have different profiles as we go through therapy. And we will see if indeed, if we see this cluster, for example, if that's associated with a good response and favorable outcome versus patients in this particular cluster that perhaps haven't responded as well. So more to come. Hopefully the data are going to be released in the next year or two, and then we'll be able to really determine whether this particular assay can really help us determine response to therapy. So in conclusion, risk classification will continue to evolve with the integration of additional genomic, epigenomic, and other biologic markers. We do have ongoing plans to revise the energy classification system using new markers, as well as analyzing the markers in patients who were treated more recently with antibody and stem cell transplant. We have to continue to speak the same language as new biomarkers are added, making sure everybody measures these the same and understands what they mean, so we can continue to compare clinical trials conducted around the world, promote international collaborative studies, and accelerate research that will improve the outcome of our patients. I would like to acknowledge everybody as a huge team effort in terms of the iEnergy Task Force, my COG collaborators, as well as, of course, the parents and patients who have been willing to share their data, enroll in our studies, and allow us to analyze their data. And of course, we have many, many supporters that are largely foundations that we wouldn't have been able to do this work without. So thank you to our funders as well. Okay. So I'd be happy to answer any questions. I have a couple right here in the chat. One attendee asked, I continue to hear neuroblastoma described as a nervous system cancer. Can I comment if that is accurate? Yes, it is a cancer that develops in peripheral nerve tissue. So it's distinct from a brain cancer, which develops in the brain, but it is nerve tissue. I don't know if how you want to describe that in terms of nervous system, but it's a tissue. It's a tumor that is derived from neural tissue. So I think the answer is yes. But it's important. Many, many people assume that a brain tumor, neuroblastoma, is a brain tumor. So it's not the CNS, but it's the peripheral nervous system, and particularly the sympathetic ganglia and the sympathetic tissue that's in the adrenal medulla. All right, next question. What's happening in the pediatrician world to remind them that various and complicated systems of a child could be neuroblastoma and should be tested for? Many pediatricians miss the diagnosis for months. Yeah, I agree. It really depends on how these patients present. If a patient presents with just a fever, that can be a lot of different things. Or if a patient presents with a limp, many things can cause a limp, including, injury, a broken bone, a problem of infection, something going on with the hip. And those are much more common diagnoses than neuroblastoma. And so it does take a little while to determine whether a patient does or does not have neuroblastoma. I can tell you that when a patient is diagnosed, this is different than adult cancers, like a breast cancer. So if you miss a breast cancer when it's localized and that patient is observed for a while without being diagnosed and treated appropriately, that breast cancer can continue to grow and metastasize. And so sometimes that patient will present with much more advanced disease, a higher stage of disease that's much more difficult to cure. In neuroblastoma, if you're going to be diagnosed with metastatic disease, that happens immediately. We don't see patients who have localized tumors if they're ignored. We don't see those tumors turn into metastatic disease. They might grow a little bit more locally, and maybe then the patient presents with a symptom that then leads to the diagnosis of neuroblastoma. But the way the patient presents in terms of whether it's a localized disease or metastatic disease, that happens, at the very get-go of the patient's diagnosis. So sometimes if a tumor is not diagnosed immediately, and it did take 2-3 weeks to be diagnosed, that would not have impacted the patient's actual stage. The stage would have still been metastatic. If it was, metastatic 3 weeks ago, it would have been metastatic when the patient was diagnosed. Do you see that diagnosis for ganglioneuroblastoma is among older children, or is it seen in a variety of ages? So neuroblastoma can either be an undifferentiated neuroblastoma tissue, or it can be a more mature ganglioneuroblastoma, which means that it has some mature ganglion cells and some neuroblastoma cells, or it can be a very mature, more benign tumor called a ganglioneuroma. And for the most part, there is an association between the more differentiated tumors in older children. So it's very unusual to see a differentiated ganglioneuroma or a ganglioneuroblastoma in a younger patient. So it is something that is typically seen in older patients. I don't know if there's any other questions. I have I think another minute or so. I'd be happy to answer.
If anyone will want to ask any question, you can send it to me and we'll pass it along. Dr. Susan Cohn, thank you so much for sharing with us your invaluable expertise today. Your dedication and advocate and in advancing treatments and understanding neuroblastoma gives so many of us, so many families, so much hope. So thank you for that. Looking ahead, we're excited to announce that our next webinar on March 5th will be focusing on a CAR-T therapy, which will be offering a new hope through innovative clinical trials for treating neuroblastoma. We'll have here Dr. Francesca Del Buffalo from Rome to share her insight and the groundbreaking research from Rome. We hope to see you all with us next month. Till then, take care and stay safe.
Thank you.
Bye-bye.